We'll now take a look at the bone remodeling cycle and also talk about bone formation. Remodeling of bone. Bone remodeling continues throughout life. Bone remodeling involves removal of small tunnels of bone by osteoclasts and replacement by osteoblasts, with no net change in bone mass. Removal occurs more swiftly than renewal. Sections of some bones are remodeled every 3 to 4 months, while for others the process takes much longer. Bone remodeling renews bone before the hydroxyapatite collagen matrix deteriorates and redistributes bone matrix to withstand mechanical stress. Moreover, remodeling provides calcium from the reservoir in bone for body biochemical functions. Later in life, it is typical for remodeling units to become unbalanced, and over several cycles bone loss can ensue. Loss of estrogen, smoking, and more sedentary activity or immobility can all contribute to an excess of resorption. Peak bone mass occurs during puberty, and accrual of bone continues into the late 20s. Puberty is the period of highest increase in bone mass because of the action of gonadal steroids and growth hormone. Genetics also play a role, but which genes are involved is ill-defined. Let's talk now about bone formation. Two signaling pathways that affect the rate of bone formation by the osteoblast have been described. And here we are talking about the wingless LRP5-beta catenin signaling system and the lipoxygenase pathway. In the WNT path, activating mutations of the LDL receptor related protein LRP5 leads to increased bone mass, whereas inhibitory mutations lead to low mass in children. In an inherited condition called osteoporosis pseudoganglioma syndrome, WNT signals LRP5 to initiate osteoblast proliferation and differentiation. So here's a quick look at the WNT signaling inhibition and WNT signaling activation. In the lipooxygenase pathway, two enzymes determine the fate of stromal cells. So in the lipooxygenase pathway, two enzymes determine the fate of stromal cells. The pathway produces prostaglandins that bind to the nuclear receptor, peroxisome proliferator activator receptor gamma, or PPAR gamma. Several studies have shown that PPAR gamma activation not only activates osteoclast formation, but also suppresses osteoblast formation. PPAR gamma is a member of a nuclear hormone receptor family that acts as a transcription factor to promote the formation of specific mRNA species. It is known that PPAR gamma plays a major role in regulating adipogenesis, lipid metabolism, and insulin sensitivity. With respect to bone, PPAR gamma functions as a switch promoting myeloid hematopoietic cell differentiation into osteoclasts, thereby promoting bone resorption while simultaneously inhibiting mesenchymal stem cell differentiation into osteoblasts, thus suppressing bone formation. The action of PPAR gamma to suppress osteoblast differentiation from mesenchymal stem cells is exerted by directing the cells to form adipocytes instead. Of note, suppression of PPAR gamma by WNT signaling enhances osteoblast differentiation by reducing adipocyte formation. The anti-diabetic drug rosiglitazone acts on PPAR gamma and has been shown to inhibit bone formation and stimulate bone resorption, thus further supporting the crucial role of PPAR gamma in inhibiting osteoblastogenesis and activating osteoclastogenesis.